two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare podcast. Today, I'm joined by my co-host, as usual, Dr. Jose Checco. Welcome, Dr. Checco.
Hi, Swapnil. Good evening.
Good evening. How are you? How's things in India?
Things are going on pretty well. We are busy as usual.
Yeah, that's good. Even in Sydney, the winter is just about to start. So, and the COVID is again on the surge. So it'll be interesting to see how the winter pans out. So today we are going to discuss another interesting randomized controlled trial, which was published in Lancet very recently. And this is a very controversial topic. Just having a conversation with some of the colleagues across different ICUs where they have neurointensive care units, the practices really vary in this particular cohort of patients. And the cohort of patients that we're going to talk about is the patients who develop spontaneous intracranial hemorrhages and how do we manage them. So the trial, which was published, called as the STITCH trial. Now, the STITCH trial has looked into whether there is a benefit of doing a decompressive craniectomy plus medical treatment versus best medical treatment alone for spontaneous deep supratentorial intracerebral hemorrhage patients. So that's a very, very specific question that these authors are trying to answer. Now, just to give a kind of bit of context, there is a guideline published in 2022 by American Heart Association around intracerebral hemorrhage. The guidelines do cover different subtopics within this area. However, just kind of focusing on hematoma evacuation. So at the moment, current practice in my intensive care unit is when the patient comes with a deep intracerebral hemorrhage, which is supratentorial and spontaneous, usually we tend to put ICP monitor and tend to monitor ICP. And if there is a significant issue with ICP management, despite optimizing all the medical management, then we do proceed to decompressive craniectomy based on age, prognosis, and all the other criteria. However, the recommendation for hematoma evacuation at the moment, based on these guidelines, is for patients with supratentorial ICH more than 20 to 30 mils volume with a GCS score of around 5 to 12, which is like moderate range. The minimally invasive hematoma evacuation with endoscopic or stereotactic aspiration with or without thrombolytic use can be useful to reduce mortality compared with medical management alone. And this recommendation obviously was changed after the publication of trial, which is called as ENRICH trial, which also published in New England Journal of Medicine recently. Now, as I said, that's not a routine practice across the globe yet, but I think in future we will probably see. So there are kind of two key interesting things mentioned in this recommendation. That one is the volume of the intracerebral hemorrhage is important. The second is the GCS is 5 to 12, which is quite a broad range, but they call it as a moderate range. So not like a worse GCS of 3 to 4. And endoscopic or the minimally invasive hematoma evacuation is the key rather than having a big surgery. Now, there are some of the other trials which were published on the same topic before, which were the STITCH 1, STITCH 2, and another trial called as MISTY trial. However, did not show any benefit with minimally invasive surgery on overall mortality and morbidity. So there is a bit of controversy around this topic. So that's why these authors conducted this trial called a STITCH trial and tried to address, because one of the criticism of ENRICH trial was it did show benefit only within the territory of basal ganglia and the cortical hemorrhage rather than a deep intracerebral hemorrhage. So I think that's why the STITCH trial is trying to look at a different cohort of patients. So Dr. Checco, can you please walk us through the methodology and the results of this trial, please?
So the SWITCH trial asks a question: does decompressive craniectomy combined with best medical care improve clinical outcomes in spontaneous intracerebral hemorrhage compared with best medical care alone? So that's the question they asked. So they conducted this randomized controlled trial. It began a long time ago, in fact, about 10 years ago, October 2014. And the trial was actually terminated in April 2023. It was conducted across 42 stroke centers in 9 countries in Europe. The study evaluated the efficacy of decompressive craniectomy in spontaneous, deep, supratentorial intracerebral hemorrhage. Patients were randomized in a 1-to-1 ratio to undergo decompressive craniectomy combined with the best medical treatment or just the best medical treatment alone. The inclusion criteria were, as I mentioned, severe, deep intracerebral hemorrhage involving the basal ganglia and the thalamus, with possible extension to the cerebral hemispheres, ventricles, or subarachnoid space. The diagnosis was based on CT or MR imaging. The study patients were to have a GCS of 8 to 13 and NIHSS score of 10 to 30, which is a scale of 0 to 42, with higher scores indicating more severe stroke. The hematoma volume was in the range of 30 to 100 mils. Randomization was meant to be within 66 hours of the onset of symptoms, and they required an INR of less than 1.5 and a platelet count of more than 100,000 for eligibility. And the decompressive craniectomy had to be performed within 6 hours of randomization. They excluded patients with a known structural abnormality that may be causing the hemorrhage. Hemorrhage involving the cerebellum, brainstem were excluded. Hemorrhage confined to the cerebral hemispheres alone, without involvement of the basal ganglia or thalamus, were ineligible. Patients with known advanced dementia or known neurological disability were excluded, and so were patients who are expected to die within 24 hours, intracerebral hemorrhage secondary to thrombolytic treatment. Patients with bilateral non-reactive pupils were also excluded. So what did they do? In the decompressive craniectomy group, they provided the best medical treatment, and in addition, decompressive craniectomy was performed with a skull flap of at least 12 centimeters diameter. The hematoma was not evacuated, and cranioplasty was carried out in about 1 to 5 months' time after the procedure. And in the control group, they received the best medical treatment alone. They calculated the sample size based on the primary outcome of a score of 5 or 6 on the modified Rankin scale. Remember, 5 means severe disability, unable to attend to bodily needs without assistance, and incontinent. 6 is dead. So that's pretty poor outcomes, 5 or 6. So they looked at a modified Rankin score of 5 or 6 at 180 days as a primary outcome. And they calculated a sample size of 300 patients, which provided the study with more than 85% power to detect a risk reduction of 33% with decompressive craniectomy at a two-sided alpha level of 0.05. So that was their plan, but then the study ran into financial difficulties after enrollment of 201 patients, and they had to cease the study at this point. And at this point of time, 95 patients were included in each arm in the final analysis. 8 patients had crossed over from the best medical treatment to the decompressive craniectomy group, and 1 patient who was randomized to undergo decompressive craniectomy received best medical treatment alone. 9 patients in the decompressive craniectomy group and 8 in the best medical treatment group underwent hematoma evacuation, which was not part of the study protocol, as I mentioned before. So the baseline characteristics were pretty much well matched. The median GCS was 10 in both the groups. The median NIHSS score was 18 versus 19 in the DC versus the best medical treatment group. Intraventricular extension was also similar, 28% versus 30%. The median hematoma volume of the whole study cohort was 57 mils. The median time from the onset of symptoms to surgery was 26 hours, and the median diameter of the skull flap was 13 centimeters. So the outcomes were, as I mentioned, the primary outcome was modified Rankin score at 180 days of 5 or 6. So these are, as I mentioned, poor outcomes. and they found that there was a signal in favor of decompressive craniectomy in terms of this outcome at 180 days, with a relative risk of 0.77, 95% confidence interval of 0.59 to 1.01. So that just about crossed the 1 mark, but it certainly looked like a favorable outcome for decompressive craniectomy in terms of the worst possible outcomes, 5 or 6 on the modified Rankin scale at 180 days. The p-value was 0.057, just short of being significant, but there was a strong trend towards favoring DC. Per protocol analysis were also very similar. 47% poor outcomes in the decompressive craniectomy group versus 60% of the best medical treatment group. And here again, the confidence interval was very similar, with an adjusted risk ratio of 0.76 in favor of decompressive craniectomy. What were the secondary outcomes that they looked at? There was a trend towards improved survival at 180 days among patients with the decompressive craniectomy group. 17% in the decompressive craniectomy group versus 27% in the best medical care alone group, p-value of 0.065. There was no significant difference in the modified Rankin score of between 4 and 6, or mortality, between the two groups at 180 days and 365 days. The median duration of hospital stay was significantly shorter in the decompressive craniectomy group compared to the best medical care alone group. 19.5 days versus 23.5 days, p-value of 0.018. So the improved survival came at a risk of more number of patients attaining a modified Rankin score of 4. So the improved survival in the decompressive craniectomy group was almost entirely due to an increased number of patients who attained a modified Rankin score of 4. 0 to 3 in the modified Rankin scale was similar in both the groups. When they looked at the hematoma volume at 48 hours and the post-hemorrhagic brain defects at 128 days, these were similar in both the groups. They also looked at the quality of life in 6 months using the Eurocore visual analog scale. The proportion of patients who needed permanent residential care was similar at 6 months and 1 year. And they did a survey of patients at study completion, asked the patients if this misfortune were to happen to them one more time, would they prefer surgery? And 77% of patients stated that they would undergo surgery again. The incidence of adverse events was similar in both the groups, 41% in the decompressive craniectomy group, 44% in the best medical treatment group. So the authors concluded that the switch study offered some weak evidence that decompressive craniectomy combined with best medical treatment might be superior to best medical treatment alone in patients with severe, deep intra-cerebral hemorrhage. However, survival is associated with severe disability in both the groups.
Thanks, Dr. Chakos. So this trial can be considered as a landmark trial because this is the first trial studying whether decompressing the brain via large craniectomy without hematoma evacuation in people with severe deep supratentorial intracerebral hemorrhage might prevent secondary post-hemorrhagic brain defects. So that's the kind of difference between the switch trial and the enrich trial, which tried minimal evacuation of hematoma rather than doing a decompressive craniectomy. And this we are talking about as a primary surgical intervention rather than reactive surgical intervention to raise ICP management. So this is the kind of difference between the switch trial versus the other trials or DECRA trial that we have seen in the past. Now, this trial has provided some weak evidence in favor of decompressive craniectomy plus medical management compared to just medical management. Again, this is the largest randomized controlled trial on this topic so far, despite the trial was stopped early due to lack of funding and I guess author was supposed to enroll 300 patients, but they end up in enrolling only 201 patients. So I guess that's the reasonable argument. It did obviously affect the overall sample size we will talk about in limitations. Now, some of the good things that this trial has done, they evaluated the long-term outcomes of the survivals. And I think that's where every single trial with either with the TBI or spontaneous intra-cerebral hemorrhage, I think that's the kind of more meaningful outcome rather than the mortality. And author not only studied at 180 days, but also at 365 days. What's the kind of overall their neurological outcomes? Now, they used a modified Rankin scale, and then they dichotomized into favorable outcome versus non-favorable outcomes. Favorable outcome being 0 to 4. Now, some people might argue that that's a broad range of favorable outcome because, as you mentioned, 3 and 4 involves some sort of dependency and might not be acceptable as a quality of life to a lot of people. But what they did in addition to measuring the favorable versus non-favorable outcome is they also asked patients who survived whether they would have kind of given a consent to this intervention if they have to suffer from the same condition again. And in fact, 77% of the patients did answer yes to this question. So I think that was the interesting part. And that's probably different than what has been done in the past, asking patients, would you undergo same intervention again if we have to suffer from the same illness? In this trial, the length of hospital stay was shorter in patients who underwent surgery with medical management versus just medical management. However, the key thing to note is the decompressive craniectomy as an intervention, it might be associated with a higher risk of CSF circulation disorder because there was an increased incidence of permanent shunting in survivors. So almost 19% patients did require BP shunts. Similarly, what is not known from this trial is some of the complications associated with the bone flap, because the flap, usually they get replaced later on, and the long-term results, complications can associate sometimes with aseptic necrosis and the resorption of the autologous bone flaps, which obviously we don't know, can't be commented based on the trial. Interestingly, the limitation of these trials are quite a lot. First and foremost is this trial was stopped early, and one of the challenges with stopping early, that means this trial is highly underpowered to give us any kind of meaningful conclusion. The second important thing, just about calculating the sample size, they assumed a relative risk reduction of 33%, and that's a massive effect on mortality to imagine in terms of calculating the sample size. Third limitation for this trial is it did include more than 42 sites, which obviously can be considered as a good thing, but at the same time, the randomization rates were uneven, and sometimes you might not get the same surgical standards across different sites, or even the medical standards might not be same across different sites, and that also adds a lot of variability interpreting those results. Obviously, this trial had to be stopped due to lack of funding, and that dragged this trial over 9 years of time. Now, one of the challenge with that period is over 9 years, most of the centers would have probably started adopting minimally invasive surgery as a primary modality by then, and would have probably not enrolled patients in the decompressive arm anyways, or long recruitment always leads to obviously selection bias as well. And the fifth limitation of this trial is the crossover rate, which was 1% from surgical arm to just the medical management arm versus medical management alone to decompressive craniectomy with medical management arm crossover was almost 8%. There's a significant crossover from second arm to the first arm. So I think that obviously could have played a significant role in changing the outcome because the sample size is very small. So there are several limitations of this trial, and that's why applying or generalizing these trial results to our population can be quite challenging. Having said that, as I said, this trial is probably the largest trial on this topic so far compared to previous trials such as Hamlet trial, Destiny trial, or Decimal trial, which also evaluated the role of decompressive craniectomy in patients with stroke. This trial has clearly given us more insight. One of the always key graph for me to look at in any trial associated with the neurological injuries is the long-term outcome modified Rankin score at 180 days and 365 days. And if you just look at the 365-day outcomes in decompressive craniectomy with best medical management group, almost 40 out of 93 patients had modified Rankin scale of 5 and 6. While in best medical treatment alone, 49 patients out of 89 had a MRS of 5 and 6. So just in general, as this pathology itself, this pathology, which is a deep intra-cerebral spontaneous hemorrhage, 1 in 2 patients will have a significantly worse outcomes. I think that's really kind of insightful information that these trials give us, that 50% poor outcomes despite a treatment arm you go into. So still we are grappling with how to salvage these patients in more meaningful way rather than just achieving the more survivors. So that's kind of my initial thoughts with this trial. Dr. Jacob, what's your thoughts?
As you rightly pointed out, Sapnal, the number of patients who actually had a reasonably, what you would call a reasonably good outcome, which is 0 to 3. I suppose most people would at least ask for a neurological state where they can at least walk without assistance. So between 0 and 3, there was no difference between the two groups, and the numbers were very few, which essentially shows that patients who suffer from deep intra-cerebral hemorrhage have a very poor outcome in general terms. And what this study actually showed was the difference in outcomes in favor of decompressive craniectomy was entirely because those patients who attained an MRS of 4 were higher in the decompressive craniectomy group. But 4, of course, is unable to walk without assistance and needs assistance for bodily needs, which may not be acceptable for many. But one of the things, of course, you need to consider, as you rightly pointed out, 77% of patients who were surveyed conveyed that they would undergo the procedure again had they were to suffer from the same problem yet again. So it is quite possible that people who might have a particular target in terms of the outcomes they would wish before they actually become involved in a critical condition, they might actually change their minds later on as well. This has happened on so many occasions, in my experience as well, where people with advanced testimony might change their mind later on and opt for a more aggressive care, even with the prospect of being disabled. So it's a little relative as to what kind of outcomes you may want. And very interesting to note that most patients who did undergo surgical intervention would have preferred to undergo the same procedure yet again. So in our practice, we do decompressive craniectomy for intracerebral hemorrhage based on the individual circumstances. As a general rule, of course, we won't do if their sensorium is intact and if the deficits are minimal. But of course, if they have profound deficits, altered sensorium, they may be strongly considered for a decompressive craniectomy, especially in the younger age group. So that's the practice we follow, and I think our practice may not change very much based on this particular study.
That's right. So there are still more trials to come on this topic. There is a MIND trial which has obviously halted at the moment, so that probably won't give us an answer. But then there are other trials such as Evacuate trial, this trial, Imminent ICS trial. They're ongoing, and the results are to be expected by the end of 2026 or 2027. And that's the kind of challenge until we get that kind of more information on this topic. It's hard to just change our practice based on this trial, which really has not shown any strong signal with regards to benefit. What is important, though, is the medical treatment alone, which is standardized, is also the key part of the management for this entity. It cannot be ignored that good blood pressure control and good intensive care supportive management for these patients is equally important. Whether you evacuate the hematoma, whether with the minimal invasive surgery, or patient end up in getting decompressive craniectomy, or patient gets managed without any surgery, I think the good intensive care along with the good blood pressure management is the key, because really you are trying to minimize the effects of bleeding on the underlying brain function, but also we are trying to prevent a rebleeding associated complications. So I think that medical management part should not be underestimated while you're caring for these patients. Now, with regards to quality of life and what is acceptable and what is not acceptable, those kind of conversations will depend on which country, which state of that particular country you practice. And unfortunately, there is so much of variability with regards to what are the accepted outcomes in this cohort of patients. Unfortunately, societal norms will play important role in selecting the treatment with regards to this entity. So it's still a very challenging area where the treatment cannot be standardized based on a trial of single results. So there's still more that we need to understand about these pathologies before we start dictating the treatments. That's the end of our today's podcast. We'll be back in month's time. Another episode. Till then, goodbye and have a nice time.
Thanks for listening. Goodbye. See you next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.